أعزائي طلاب المرحلة الثالثة، السلام عليكم ورحمة الله وبركاته. Our lecture about diseases of hepatobiliary system and pancreatic disorders. In this lecture, we discuss jaundice or hyperbilirubinemia, or also called icterus, liver cirrhosis, and liver failure. We start with jaundice or icterus or hyperbilirubinemia. It is an abnormally high accumulation of bilirubin in the blood, and the patient with jaundice presents with yellowish discoloration of his skin, sclera in the eye, and also yellowish discoloration of deep tissues. To understand the causes of hyperbilirubinemia and the diseases that included in this situation, normal physiologic pathway of bilirubin synthesis should be discussed. After 120 days, all red blood cell will be lysed. The hemoglobin inside the red blood cell will be processed to heme and globin. The globin reused as a protein or recycled. The heme ring will oxidize to biliverdin. The biliverdin then converted to bilirubin. The bilirubin here is unconjugated bilirubin and insoluble in water. Till now, this process is a pre-hepatic process. That means before the level of the liver. The unconjugated bilirubin, insoluble in water, transported in blood by a carrier protein. Then this unconjugated bilirubin enter the liver. And inside the hepatocyte, this bilirubin converted to conjugated bilirubin, which is soluble in water, collected by the caniculi toward the bile duct. Here inside the hepatocyte, this pathway is a hepatic pathway. Then the bilirubin excreted to the intestine by the bile duct, and the process of excretion of bilirubin is a post-hepatic pathway. Inside the intestine, the conjugated bilirubin converted to a highly soluble bilirubin called urobilinogen. About half amount of urobilinogen will be reabsorbed to the blood again and re-excreted by the liver. 5% of reabsorbed urobilinogen will be further excreted by urine. The rest of urobilinogen released with feces as a urobilin or stercobilin. From this pathway, we know that we have a prehepatic, hepatic, and post-hepatic pathway. And we can conclude that the hyperbilirubinemia may result from excessive destruction of red blood cell, and it represents a prehepatic causes, or impaired uptake of bilirubin by liver cells, decreased conjugation of bilirubin, and they are represent hepatic causes. Or the hyperbilirubinemia may result from obstruction of bile flow in the canaliculi of the hepatic globules or in the intrahepatic and extrahepatic bile ducts, and it represents a post-hepatic causes. So from an anatomic standpoint, the disease that causes jaundice can be categorized as first, a prehepatic causes, second, intrahepatic causes, third, post-hepatic cause. In prehepatic causes, there will be an excessive red blood cell destruction. That means hemolysis of the red blood cell. And in this category, all diseases that lead to intra or extravascular hemolysis included, from hemolytic blood transfusion reaction, hereditary disorders of red blood cell, sickle cell anemia, thalassemia, spherocytosis, acquired hemolytic disorders, hemolytic disease of the newborn, autoimmune hemolytic anemias, all types of hemolytic anemias, whether intra or extravascular hemolysis, are included in prehepatic jaundice. Second, intrahepatic causes, and here there will be impairment in the uptake of bilirubin by the hepatocyte, or decrease conjugation due to a congenital defect in enzymes required for conjugation. There will be hepatocellular damage, hepatitis like viral hepatitis, hepatitis B and C, cirrhosis, cancers of the liver, or there will be a drug-induced cholestasis. These are intrahepatic cause. The intrahepatic cause mean diseased hepatocyte. And the most common intrahepatic cause is hepatitis, viral hepatitis. Post-hepatic, and as we say, post-hepatic mean obstruction of bile flow. There will be either structural disorders of the bile duct, and this may occur after surgical manipulation and as a complication of adhesion and fibrosis after surgical operations, or there will be a congenital atresia of extrahepatic bile ducts. It is a congenital abnormality. The infant born with this congenital defect, or obstruction caused by tumors or stone, cholelithiasis. The most common tumor that lead to obstruction of the bile duct is the tumor of the head of the pancreas. And the most common cause for post-hepatic jaundice is the stone that obstruct the bile duct. In order to correlate the hyperbilirubinemia with lab test and to detect the main cause for hyperbilirubinemia, total serum bilirubin lab test will be done, and the total serum bilirubin will be increased. If total serum bilirubin increased, differential bilirubin should be done, i.e. we do conjugated and unconjugated bilirubin test. If the unconjugated bilirubin increased, so the cause is a prehepatic cause, and we think about hemolytic disease. If the conjugated bilirubin is increased, so the cause is either hepatic or post-hepatic. Now, we start with the second topic in our lecture, which is liver cirrhosis. Cirrhosis is not a disease by itself. It is the end result of many conditions that destruct the normal architecture and normal histology of the liver lobules. It has the following important structural features. Please know that the cirrhotic liver have a destruction of liver parenchyma and separation of lobules by fibrous tissue with formation of abnormal nodules and abnormal vascular architecture. Here we have in the left side normal picture for liver parenchyma, It is normal histology. And histology of the liver, we know that the liver consists of lobules with central vein in the center and portal vein, hepatic artery in the periphery of each lobule. On the right side, this is a picture for cirrhotic liver. In cirrhotic liver, the lobules will be surrounded by a fibrous tissue, then progressively converted to nodules surrounded by thick fibrous tissue, as we see, and abnormal texture of the vessels that between these nodules. Here we have distracted parenchyma. The normal liver will be converted to nodular liver with excess amount of collagen. Collagen will be accumulated between the lobules. Fibrous tissue will separate lobules. Nodular liver will be present and the architecture of the liver will be distracted. The characteristic feature of liver cirrhosis is accumulation of collagen and excess extracellular matrix. The pathologic pathway include that in genetic predisposition and in the presence of repetitive damage, whether by toxins, toxic bile salts, in autoimmune disease, viral hepatitis, especially hepatitis B and C, oxidative stress, insulin resistance, and so on. Cells, inflammatory cells inside the liver, like macrophages and T lymphocyte, will release cytokines and chemokines with transforming growth factor beta and reactive oxygen species. All these inflammatory mediators will convert the portal or perivascular fibroblast to activated myofibroblast. These activated myofibroblast will release large amount of collagen. This collagen will be accumulated between the hepatocytes and cirrhotic liver will occur. We can classify the cirrhosis according to its causative agents and resultant pathologic configuration as biliary cirrhosis, post-necrotic cirrhosis, and alcoholic cirrhosis. In biliary cirrhosis, there will be obstruction of one or more area of biliary passage, either by obstruction by stone or by autoimmune disease, or could be idiopathic, primary. The obstructive biliary passage will result in bile stasis. The bile will extravasate to the surrounding hepatocytes. Injury and scarring will occur, and evidence of fibrosis will result. Second, we have post-necrotic cirrhosis. Here it follows massive liver necrosis and involves the destruction of lobules and even loops of the liver. It can occur after viral hepatitis, autoimmune hepatitis, or after exposure to hepatotoxins such as certain drugs. Viral hepatitis, drugs, or autoimmune diseases lead to necrosis of the hepatocytes with subsequent fibrosis and cirrhosis. alcoholic cirrhosis, it is the most common cause of cirrhosis, and about 75% of alcohol-related deaths are attributed to cirrhosis. For that reason, stages in development of alcoholic cirrhosis will be discussed. The first stage is stage of fatty change. Here there will be excessive accumulation of fat within liver cells and cause liver enlargement. The alcohols replace fat as a fuel for liver metabolism and impair mitochondrial ability to oxidize fat. In this stage, the patient usually asymptomatic and it is a reversible process. Once the alcohol intake has been discontinued, the liver and hepatocyte reverse to normal. The second stage is the stage of alcoholic hepatitis. It is an intermediate stage between fatty changes and cirrhosis. It is characterized by inflammation and necrosis of liver cells, thus is always serious and sometimes fatal. The necrotic lesions are generally patchy but may involve entire loop. This stage is characterized by hepatic tenderness, pallor, anorexia, nausea, jaundice, ascites, and liver failure in some cases. But some patients may be asymptomatic in this stage. Third stage is stage of cirrhosis. Cirrhosis is the end result of liver injury caused by fatty liver and alcoholic hepatitis. The normal liver structure is replaced by bands of fibrous tissue with areas of regenerating cells. As the disease progresses, the liver will shrink and become smaller in size. And the picture above shows the healthy liver, then the fatty liver become yellowish in color and increase in size. And in the third picture, it is liver with cirrhosis, become nodular and shrink, become smaller in size. Clinical manifestation ranging from asymptomatic hepatomegaly to symptoms of hepatic failure. The early manifestation of cirrhosis just about right upper hypochondrial pain and sensation of fullness due to hepatomegaly. But the late manifestation represented by manifestation or clinical feature of portal hypertension and liver cell failure. Portal hypertension occur by fibrotic bands that cause narrowing of the portal vein to cause portal hypertension. It is followed by backward congestion of all tributaries of portal vein. And as we know, the patient with portal hypertension present with hematemesis, recurrent episodes of hematemesis, and may present with an emergency picture, which is upper gastrointestinal tract bleeding. Second manifestation include hepatocellular failure. The liver lost its function and the patient present with jaundice due to decreased production of bile, ascites due to decreased plasma protein synthesis, bleeding due to decreased blood clotting factors. As we know, it's synthesized in liver. And hepatic encephalopathy due to accumulation of metabolic byproduct and toxins like bilirubin and ammonia and other substances in the circulation since the liver loses its detoxification capacity. This is one of the reasons of hepatic coma to occur. The stages of cirrhotic liver clinically divided to 4 stages. The first and second stages called compensated cirrhosis. The third and fourth stages called decompensated cirrhosis. As we say, these stages are correlated with a death percent. In stage 1 and stage 2, the death percent about 1 to 3%. And in stage 1, there is no varices, no signs of portal hypertension, and no ascites. That means the hepatocyte is still functioning and synthesize proteins. In stage 2, there is a varices, the portal pressure start to be elevated, but no ascites. In third stage, there will be ascites and varices. In stage 4, a bleeding and ascites. The death percent increase in third stage to 20% and in fourth stage to 57%. So in stage 4, the death will occur in more than half of patients. Liver failure. The most severe clinical consequence of liver disease is hepatic failure. It is the end result in severe diseases of the liver. It may result from sudden and massive hepatic destruction, as in fulminant hepatitis, like that occur in viral hepatitis, especially hepatitis C, the liver attacked by virus, and massive loss for hepatocytes will occur, and the patient suddenly present with fulminant hepatitis. Or it may be the result of progressive damage to the liver, such as alcoholic cirrhosis. Whatever the cause, 80 to 90% of hepatic functional capacity must be lost before hepatic failure occurs. The manifestation of liver failure reflects the impairment of various synthesis, storage, metabolic, and excretory functions of the liver. Fetor hepaticus, which is a new term in this lecture, means a characteristic musty sweetish odor of the breath in the patient with advanced liver failure. It is a characteristic smell and characteristic odor in the mouth of patient and in breath of patient with liver failure. It is called fetor hepaticus. When liver failure, the liver lost its synthesis and storage function, and this includes glucose. So the patient have hypoglycemia, protein synthesis will be lost, so the patient present with hypoalbuminemia or decreased coagulation factor synthesis, and the patient present with edema, ascites, and bleeding. Defect in lipoprotein synthesis and cholesterol, so the cholesterol will be decreased. Bile salt synthesis, so this will lead to impairment in fat absorption, and this will lead to deficiency of fat-soluble vitamins and fatty stools. The other function is a metabolic and excretory function, also will be lost. Amino acid conversion of ammonia to urea occur inside the hepatocytes. So the ammonia will be elevated in blood, leading to encephalopathy and coma. Steroid hormones there will be increased aldosterone and increased androgen and estrogen. Aldosterone, when increased, lead to edema and ascites. It accumulates fluid inside the body. While increased androgen in female lead to menstrual irregularities, and estrogen in male lead to gynecomastia and testicular atrophy. Drug interaction and drug intoxication will occur because the detoxification capacity of the liver will be lost. Bilirubin synthesis will be affected, so the patient presents with hyperbilirubinemia and jaundice.